Hello everyone, welcome back to my YouTube channel Dr.Barki's Ophthalmology Tutorials. Today we will discuss about superior oblique palsy or fourth cranial nerve palsy. It is one of the most toughest topics for the postgraduates and even for the clinicians, that is ophthalmologists. It is little difficult to diagnose these cases and manage these cases of superior oblique palsy. So let's discuss the superior oblique palsy under the headings of introduction, what are the causes for superior oblique palsy, what are the symptoms and signs. In the signs I will be explaining about Park's 3-step test and classification of the superior oblique palsy, the NAPS classification, how to differentiate superior oblique palsy from the skew deviations, what are the features in the bilateral superior oblique palsy, as well as the management, which includes the investigations as well as the treatment modalities for superior oblique palsy. So without much delay, let's begin our video on superior oblique palsy. The superior oblique muscle is supplied by the fourth cranial nerve, which is nothing but the trochlear nerve. I have discussed the fourth cranial nerve anatomy in my previous videos. Please do watch that video to know about the anatomy of the trochlear nerve, then come to this video, okay? So the trochlear nerve is a pure motor nerve which will supply the superior oblique muscle. So if there is any dysfunction of the trochlear nerve, it will lead to superior oblique palsy. Then it will lead to the paralytic squint. So this is one of the cyclovertical muscles which has the action of both torsional movements as well as the vertical movements. So this is one of the cyclovertical muscle. So it has 3 actions depending upon the position of the eyeball. So in the primary position, when the eyes are looking straight, that is the eyeball. So this is the orbit. We have the superior oblique muscle which is coming and getting attached here. So this is the visual axis. In the primary position, the action of the superior oblique muscle is intorsion. When the eyes are adducted, it acts primarily as a depressor. When the eyes are abducted, it acts to intort and abduct the eye. So these are the 3 actions of superior oblique muscle: intorsion, depression and abduction. So whenever there is palsy of the superior oblique muscle, these actions are not met. So the eyeball is in hypertrophic position because there is no depression, and it is in excyclotorsion as there is no intorsion happening. Okay, so the affected eyeball is in the hypertrophic position with the excyclotorsion. Okay, that is the position of the eyeball in the superior oblique palsy. Now moving on to the causes for superior oblique palsy. So it can be isolated superior oblique palsy, or it can be associated with paralysis of other cranial nerves, which may include 3rd, 6th or even the 5th cranial nerve or even the optic nerve. So the causes for isolated superior oblique palsy, we have the congenital, which is most common, traumatic causes, microvascular diseases like diabetes and hypertension, and it can be idiopathic in 4% of cases of superior oblique palsy. And it can be associated with other cranial nerves following trauma, or there can be neoplasm, infection, inflammation, or even the raised intracranial pressure can also lead to superior oblique palsy with the other cranial nerve palsy. But here you will have to locate where exactly the lesion is. The lesion can be at the midbrain, or it can be at subarachnoid space, or it can be in the cavernous sinus, or it can be intraorbital. So depending upon other associated signs, you can locate the lesion to one of these areas. So what are the usual symptoms of the superior oblique palsy? So if it is evident superior oblique palsy, patient will have double vision with a vertical tilt. Okay, it's more obvious in the down gaze. Okay, that is one symptom. And the patients may also have the asthenopic symptoms of the neck stiffness or the abnormal head posture. So depending upon the history, whether it's congenital or acquired type of the superior oblique palsy, the symptoms will vary. So how these congenital superior oblique palsy children will present? Usually they will not have the double vision, because they will compensate for the double vision by their varied head position. That is, they will have the head tilt towards the opposite side, which will elevate the diplopia. So the major symptom of the congenital superior oblique palsy is the abnormal head posture, and they can also have the chin down position if they have bilateral superior oblique palsy. And later as they grow, if there is decompensation of the fusional mechanisms to elevate this double vision, then they will manifest with the double vision. So absence of double vision in spite of having superior oblique palsy with abnormal head tilt is a sign of the congenital superior oblique palsy. Sometimes even the congenital superior oblique palsy can have the hypertrophy of almost 10 prism diopters, but still they may not experience double vision. Whereas in case of acquired superior oblique palsy, the double vision is the most common symptom which they present with, and they will also have what is known as the image tilt. Coming to trauma as a cause of superior oblique palsy, it accounts for almost 34% of all superior oblique palsy cases. So even the minor, the trivial trauma can lead to superior oblique palsy. So if there is unilateral superior oblique palsy, again they will have double vision as well as the abnormal head position. There can also be bilateral superior oblique palsy following trauma. So when you subject these patients for the MRI, then you will find the lesions at the dorsal midbrain, like there can be infarction or the hemorrhage at dorsal midbrain. Coming to microvascular causes, that is diabetes and the hypertension as the cause for superior oblique palsy. So here the patient will have sudden onset of painless double vision. Okay, so which is again worse in the down gaze. So usually these patients will not require any imaging modality. You can follow up these patients for 6 months and look for the improvement. But if you do MRI, you will find the lesion at the fascicular level, which will usually resolve in 4 to 6 months. It can be idiopathic in some cases where you will not find any cause for superior oblique palsy. So coming to superior oblique palsy associated with other cranial nerve, as I told, it can be associated with other cranial nerves like third cranial nerve or sixth or second or even the fifth cranial nerve. So the lesions can be at the level of midbrain, subarachnoid space, cavernous sinus and even the orbital lesion. So when the lesion is at the level of the midbrain, it can be secondary to infarction or the hemorrhage. Usually they will have hemisensory loss. There can be ataxia or the eye also present with central hornus, and it is associated with third cranial nerve palsy. And if the lesion is at the level of the subarachnoid space, the patient will have fever, headache and the neck stiffness. So if the lesion is at the level of the cavernous sinus, they can have third and sixth nerve along with the trochlear nerve palsy. They can also have the Arnold syndrome. If the lesion is in the orbit, then the patient will have proptosis, chemosis and even the orbital edema. This is how you will classify whether it is a congenital SOP of the superior oblique palsy or the acquired SOP. And in the acquired cases of superior oblique palsy, this is how you locate the lesion to various anatomical locations. I have already mentioned the symptoms of the superior oblique palsy. If it is of acute onset, they will have the double vision, that is the vertical or the torsional diplopia, which is worse in the down gaze. They can also have the symptoms of asthenopia or the neck stiffness or the abnormal head posture. So moving on to the signs. So when you do the examination of the superior oblique palsy patient, the ocular examination should include everything, right from the vision, anti-segment evaluation, the fundus examination, followed by the squint evaluation. And when you do squint evaluation, here you will find that the affected eye is in the hypertropic and the excyclotorted position. Okay. And you can measure the amount of hypertropia by Prism-Barkova test. And when you plot the diplopia charting, you will have the torsional diplopia. So that is, the one image is straight and there is tilting of the other image. Okay. So now moving on to the important test of superior oblique palsy, that is Bielschowsky 3-step test. So here you are looking for the paralysis of one of the cyclovertical muscles of both the eyes. So whenever the patient has hypertropia, then there is a possibility of involvement of the cyclovertical muscles. That is nothing but superior rectus, inferior rectus, or the superior oblique and the inferior oblique of either eyes. Okay. So first is you are looking for only the paralytic muscle. It is not the overaction of the muscle which you are looking for. So let's consider a scenario where there is hypertropia of the right eye. Okay, there is right hypertropia. So that means that there is left hypotropia. Which are all the muscles which can lead to hypertropia of the right eye? The depressors of the right eye are not working. So there can be paralysis of the right inferior rectus or the right superior oblique. So similarly, if there is left hypotropia, it means that the elevators of the left eye are not working. So there is palsy of left superior rectus or the left inferior oblique muscle. So now we will ask the patient to look into either gazes, either to the left or the right, and see where the hypertropia is increasing. So if you ask the patient to look into the left gaze, so in the primary position there is hypertropia of the right eye, and now you are asking the patient to look into left gaze, that is the levo version. In this case there is adduction of the right eye and abduction of the left eye, and the superior oblique is a depressor in the adduction, as I told before. So that is not happening, so the hypertropia will increase, or there can be problem with the recti of the left eye. So we have the left superior rectus here and the oblique, that is right superior oblique here. So we have the right superior oblique muscle or the left superior rectus muscle as the possible causes for hypertropia which is increasing in the left gaze. The third step is, now you ask the patient to tilt his head. Okay, so when you ask the patient to tilt head towards the same side, ask the patient to tilt towards the right side. So normally when we tilt the head towards the right side, there is intorsion which is happening. So when we look at the object and tilt our head, there is intorsion of the eyeballs which is happening. Since there is superior oblique palsy, the intorsion is not happening. So the next intorter of the right eye, that is the superior rectus, will come into play. So it will try to intort the eye. But the superior rectus also has the action of elevation of the eye, which is unopposed by the superior oblique muscle. So there is increase in hypertropia when tilting the head towards the same side. That's how we will come to the diagnosis of the superior oblique palsy here. That is, right side superior oblique palsy is affected. So whenever there is superior oblique palsy, it becomes worse. That is, the hypertropia will increase in the opposite gaze and same side head tilt. Okay. So the mnemonic to remember this is boot, that is better on opposite tilt. So if you remember this, you can get the other things. So it is becoming better on the opposite tilt. It means that it is becoming worse on the same tilt, worse on the opposite direction, that is wood. So remember these two mnemonics, boot and the wood. Boot is better on opposite tilt and worse on the opposite direction. So this is about Park's Bielschowsky 3-step test. So the other things, that is the NAPS classification, how to differentiate from the skew deviation, how to differentiate unilateral from the bilateral superior oblique palsy, as well as the management I will discuss in my next video. So hope this video on superior oblique palsy is helpful to all of you. If you like my videos, please do subscribe to my channel, press the bell icon for further notification. Please do like and share my videos and leave your valuable comments. Thank you so much.